Hi, this is Brian Werbers doing a lecture on the continuation of care of patients with respiratory infections, and specifically on this one we're going to be talking about pneumonia and TB. So with this, realize it affects patients of all ages, similar to those other infections. Inflammation of the interstitial spaces, alveoli, bronchioles from the invading organism or other agents, and then that ultimately leads into gas exchanges impaired. So with this, it's health promotion for some of the stuff. For those that are immunocompromised or at severe risk, and those that are 65 or older may qualify for immunization. Hand washing is paramount once again. It's nursing, so we have to be washing our hands and caring for those patients. And then people that are on ventilators, we do want to do aseptic and good practice in trying to avoid ventilator-assisted pneumonias. So subjective, we want to talk about those histories of risk factors for pneumonia. Have they ever had it before? Have they been around anybody with pneumonia? Those type of situations. Any history of drugs or alcohol abuse? Do they have a present NG or recently on a ventilator? History of past respiratory illnesses or infections? Or do they have a history of chronic respiratory problems which might make them more susceptible to having a pneumonia? Objective, they might have some flushed cheeks, running a fever. They might be anxious, especially if they're having a hard time breathing. They might have some chest pain, myalgia, headache, cough, tachycardia, tachypnea, and increased sputum production. Chest muscles might become weak because of all these different things and the difficulty in breathing. They might have some crackles and wheezes in those lungs and possibly diminished lung sounds of the affected lobe. So with this, they might also have orthostatic hypotension related to not breathing well as if they're not eating well, they might become dehydrated. Diagnostics on this, things that we might do, ABG to look for the gas exchange and see how that is doing. We might look for inflammation related to asthma. We might do sputum cultures, trying to specifically look at and see what type of pneumonia this is and what's causing it. Do a CBC, especially with that WBC, to look for increased counts to see if there's an infection. Cultures, if possible. This can get septic, and so we might do blood cultures to see if patients become septic off of this. Electrolyte imbalance. Once again, if they're dehydrated related to this, you might want to know about that. And then looking at the BUN and creatinine levels to see if the kidneys are involved with this and see if they've taken a hint or how dehydrated the patient might be. Imaging, of course, a chest x-ray is probably our biggest thing that we'll do on this one. It's probably our gold status. We also might do a CT, which is just a series of chest x-rays. So, pulse oximetry, you might see that is decreased on this one as they're having difficulty in converting the oxygen into their bloodstream. And we might do a transtracheal aspiration or bronchoscopy, trying to get that a sample of that organism so we know appropriate treatment with antibiotics. So for nursing diagnosis, we do have risk for impaired gas exchange related to ventilation and perfusion. With this, we want them to be setting greater than 95%, have an absence of cyanosis, and maintain a good level of consciousness. Interventions that we might use would be oxygen delivery. That can be via nasal cannula, mask, intubation, etc., etc. Might also do incentive spirometry, trying to prevent atelectasis. This is very commonly used, especially after surgeries and other periods of time where people might be bedridden for a little bit and they can't get up. With this, we want to encourage this very frequently, like every 10 minutes or so. Risk for airway obstruction. So with that pneumonia, it might be significant enough in which it's causing an obstruction, and that's going to definitely impede our oxygenation. So things that we can do: cough, turn, deep breathe, for, every 2 hours. Using that incentive spirometry to try and encourage deep breathing. Increase PO fluid to try and thin any secretions and prevent any dehydration. Might administer some bronchodilators. This is not always the case, because I know some pulmonologists feel that if you open up the airways, then the influenza can seep deeper into those tissues. but I do know sometimes it is prescribed to help those people out that are having decreased airflow. Maybe some steroids, just trying to decrease the inflammation. Maybe giving some expectorants like guaifenesin, if I could say the word, guaifenesin, and just trying to thin those secretions and get rid of any extra sputum. Risk for sepsis, this can cross into the blood barrier, into the bloodstream, and of course then we have to worry about sepsis with this one. So some of the things we'll probably do with this is look for blood cultures, and then of course see if that WBC counts are within normal limits. With this, if we are suspecting sepsis, of course we're going to treat with anti-infectives specifically towards that organism. If taken as an outpatient, make sure that they complete the dose. That's common nursing education 101. And then, of course, they should return if they're having signs and symptoms or their fevers are not resolving. Once again, avoid those crowds, not so they spread it to other people. And then they should avoid smoking or other irritants so that they don't make it worse. Alright, so as you're looking at this, the nurse is caring for an 89-year-old patient admitted with pneumonia, has an IV running, antibiotics that were initiated, has oxygen going. And what's your priority diagnosis for this? So what do you think? Is it A, the patient is alert and oriented, person, place, and time. B, blood pressure is within normal limits in patient's baseline. C, behind the ears. Skin behind the ears demonstrates no redness and irritation. Or D, urine output has been greater than 30. So of course we probably want to do all these types of situations, but probably the priority diagnosis is going to be alert and oriented, person, place, and time. If they start getting confused, that's a really bad sign for either the dehydration, which is a background and secondary, or that they're not getting enough oxygen. And so that would be the priority diagnosis. Alright, transitioning on to tuberculosis. This is yet again another communicable disease. This is a bacteria specifically. It's transmitted by aerosolization, and this is an airborne infectious etiology. So that's a little bit different. Remember, with airborne isolations, you do need to have the room that's a negative airflow room. So we're pulling the air from the outside of the hallway in, and that way the TB doesn't escape into the hallway and infect other people. It's also running through different filters when it does that. When we are in those rooms, make sure that we have to wear the specialized masks or even PAPRs, which are those positive airway pressurized masks. Patients are contagious when manifestations are present, and of course we got to treat that accordingly. There are some risk factors for those people with HIV, AIDS, or that are homeless or incarcerated. So, best thing to do is have an early detection of TB, looking at those subjective findings. The bad thing is these tend to be very vague in nature. But we'll look and see, do they have a history of exposure, any travel to foreign nations, have they ever had the BCG vaccine? Some people have had a skin test, forgot that they had the BCG vaccine, and then the skin test turns positive and they kind of freak out a little bit. So we do have to kind of watch this a little bit. They might have a history of previous skin tests being positive, especially if they had the BCG vaccine. But they should report any fatigue, lethargy, nausea, anorexia, weight loss, irregular menses, low-grade fever, cough, especially if they've got a blood-tinged sputum to it, or night sweats. And as you can see, a lot of these are pretty non-specific things. So that's what makes the TB kind of difficult for us. Diagnostics, of course, we're going to test for it, so we can use the NAA, so nucleic acid amplification. We can also use quantiferin gold. Otherwise, we can use some of the tuberculin tests, which are Manitou tests, and just trying to figure out if they are positive or if they've been exposed to tuberculosis. Sputum culture ultimately is another form of diagnosis, and it can also be used to look at the effectiveness of therapy. And then a chest x-ray is often done to look at active versus inactive lesions, so tubercules within the chest cavity. So looking at the Manitou, we're trying to see, how big these red marks are, if any, to see if they've been exposed to TB. Planning and implementation with this, so often it's combination drug therapy that's used to destroy those organisms, and we want to be very aggressive with this, not so we induce drug resistance with this. It is kind of rare within the state of South Dakota that we have drug resistance, but it's still possible. First line therapy is often INH and rifampin, so you get a couple of months therapy with that one. They might include some different medications in regards to this, depending on the type of TB that they have. There are some good teaching things with this one, is that we do want to avoid alcohol, because the ethambutol will kind of make them react with that, make them sick. We'll increase the PO fluid intake for the pyrazidine, and then rifampin can stain things yellow. You could ask me how I know on that one, but it will stain your contacts, your bed sheets, any white shirts you have, any of those type of things. As you sweat, you will leach that yellow coloring out into things around you. INH should be taken on an empty stomach. Oftentimes we do have direct observed therapy for this one, meaning that a nurse or somebody specific has to watch the patient take these meds. And that is done to protect the community and make sure that they are taking their medications. These medications often are offered as a free basis, especially as we're trying to protect the community with this one. All right, intervention. So convalescing occurs mostly at home. So initially they might be hospitalized. Once they are under control and they've got some negative sputum cultures, they can go home and recover at home. Because then after 3 consecutive negative tests, then the patient's no longer infectious, although they are still recovering. As I mentioned before, directly observed therapy may be indicated if the patient is at risk of not taking their medications. While inpatient, of course, this patient is going to be on airborne precautions like we talked about before. So that concludes this lecture on specifically about TB and pneumonia. If you have other questions, please contact me.